Hey guys, welcome to our second webinar. And this time is going to be, is going to be by Dr. Mario Tai, which is our co-founder, and he has like 5,000 something patients already. So he's very good at finding all the details about the cases and how to make them work with all the tools that Titan offers. So this is going to be a very valuable webinar. Uh, the idea here is that Dr. Mario Tai is going to show how he normally does a case, uh, and show you the small things that he has found to make it fast and be able to to use more time for your patients. Um, he's just joining in. Just waiting. Yeah, in while he's joining, so we're planning on doing this webinar. Oh, here he is. Hey, Ty.
Hey, how
Uh,
you guys doing?
yeah, I was just introducing you that you're gonna be showing, how do you use Titan in
Okay,
your office,
yes.
and showing a case that from start to finish as you normally do, so that doctors can pick the ideas that works for their own office. And what I was saying here is that these webinars, we're trying to make it as to the point as possible, so that you could use it on your office as you normally would use. And every week we're going to have a speaker showing how they use it in their office. um, yeah. Oh,
Yes, so
here.
let me share my screen. Okay, can I do that right now? Okay.
Yep.
Host is disabled. Okay, there you go. Good. So today I want to share, let me just do this quick. Okay, there you go. You guys see my screen, yeah? Can everybody see my screen?
Yeah, we do.
Okay, give me 1 second, okay? I'll be right back. Okay, well, thank you so much for joining this webinar today. And today I wanted to show you guys how to, um, set up a case um, in a time frame that I would do it within the hours that I'm working. What I mean by that is I try not to spend too much time outside of work doing cases. Our goal with Titan is to really to be able to, work within the hours that we're in the clinic so that we don't have to spend so much time doing homework, right? I know a lot of times for in-house liners, we have to do a lot of, homework per se. And for this case, it's very interesting because it's not an easy case. It's not a crazy hard case, but it's a good case to present that it's in the moderate severity zone. So we have a patient here. Her name is Clarice. She's very lovely. She's really nice. And she came to me. She's 27 years old, and she's complaining about lower crowding, and for her upper, she has some crowding as well. And after looking at her, records, which all of us need to do for her SEP, for her panoramic, and then making sure everything is nice and healthy with her periodontium, with her perio and whatnot. Um, then I mentioned to her that I could do a treatment plan for her. And what I did for her on the same day is that I saw her in the morning and I let her know that perhaps after lunchtime I can see her and then I can show her what's possible. And with this situation, I wanted to point out a few things. I mean, we did characterize this YouTube as a tips and tricks, but I do want to share with you something that I always keep in mind, when I do cases. And let me get to that page here. Um, so, in this, so here, if you guys can you guys still see my screen? Frank, are you still there? Can you still see my screen?
Yes, yes, Mario.
Okay, thank you so much, Jose. How you doing, buddy?
Everything okay? Go ahead. It's beautiful.
Okay, so we always want to understand that we're going after a healthy, happy smile, right? Which means it's form, function, and stability. This is very, very important, right? We need to understand and respect the bones, the teeth, the TMJ. So we always got to keep that in mind. And then also another thing that I want to mention is what you see is not always what you get, right? So this is where like overcorrection comes in, over expansion comes in, understanding that sometimes what we treatment plan with the software, right, may or may not happen. And this depends on a lot of things, right? So following the next option, not the next option, the next point I want to point out is we really got to respect the periodontium, right? So in order to have form, function, and stability, we look at the age of the patient, whether they're teenagers, whether they're minors, whether they're adults. We've got to look at their biotype, look at how much bone they have, determine what to do, what not to do based on all these items. Sometimes, we notice that for younger kids, we can do a little bit more, we can do a little bit more, dental alveolar expansion, right? And for adults, sometimes we're able to do the same thing, but sometimes we're not. So we really got to understand what to do, what not to do, okay? So let the biology lead the case, the biology of the patient themselves, and we got to identify that. These are very, very important because sometimes you see cases, you're like, wow, that's incredible. How do they do a certain treatment with adults, with a lot of crowding, with no extractions, with a lot of expansions, and you're like, are we causing fenestrations? Are we causing, periodontal damage, but at the same time, it really depends. So we got to keep that in mind. One of the latest articles that was just published by AAO, it states that, and this just came out, literally, I got the email yesterday, and it talks about, a liner treatment, causes, periodontal damage. And it says non-extraction, for non-extraction cases. But really, we have to understand which ones, right? A lot of times research tells us, oh, statistically something is working or something is not working. But sometimes when it's 80% not working, we have to also remember the 20% that did work. So it's very important to identify individually per patient. All right. So, and then also, I always remind myself, right, with all that in mind, respecting occlusion is very important, right? How our teeth fits in. Our teeth is like a puzzle, especially for adults. It's already, occluded for so many years. Patients are chewing, they're eating, they're grinding, and there's, different shapes. All the teeth are now in different shapes, in different fits. So you have to respect that. A lot of times we need to occlusal adjust as we move teeth, or at the end, we have to look for interferences. So a lot of times it's not just, oh, if I'm a great orthodontist, I never touch the teeth. The shape, the form stays the same throughout. I'm telling you, like 30 years ago, 25 years ago, when I have professors teach me, and they're like 70 years old, a lot of them tell me things like, hey, if you're a great orthodontist, you don't touch the teeth, you don't occlusal adjust. And then we realize that's really not the case. It's form, right? It's a form, the function, the stability. Form is very important. It's not just the form of the whole occlusion, it's the form of each individual teeth. So we got to look at that and keep that in mind in order for any orthodontic treatment, whether it's fixed appliances or whether it is, using aligners. So we really got to respect occlusion, okay? And then always remember, right? We got to win the battle in order to win the war, right? So one battle at a time, it's the whole picture. We got to always navigate like we're sailing, right? We have a navigation plan, we have a treatment plan, but we have refinements. The refinements doesn't mean we did something wrong. Refinement just means we are reacting to the body, the biology of the patient, perhaps the compliance of the patients, and so we have to really look at the whole picture. Everything is very individualized. There's no one formula that will or not even one general formula. Everybody is so individualized. We learn all the tools, we have all the toolboxes, we have to use the tools, and sometimes, use one tool for something else. So we have to really be outside the box, inside the box, and really, ask and learn and constantly, navigate, right? Look at the environment, look at ourselves, look at the patients. So I wanted to point these things out. So with this, general, kind of, mental, state of mind, I should say, this is how I approach all my cases. So I just wanted to mention that today. Now let's go back to the case that I want to share with you all. So Clarice, she's super cool. She's very nice. She was actually pregnant when she came in. And I wanted to mention that because a lot of people say, oh, if you're pregnant, you should perhaps wait to do orthodontics. And yes, that's true too, because if you do things like, fixed orthodontics, if you do a lot of appliances, it may or may not affect, and you have to, watch out for pregnancy diabetes, you have to watch your gums, your gingival hyperplasia, sometimes that happens. But other than that, you also got to remember, right? Individual. Somebody who's pregnant has hormones blossoming all over their body. If the baby's growing, the mother's growing, their body, their cells are almost at a different state. Their teeth could actually move faster because everything is under like developmental, under repair. It's like awakened. So sometimes, even though they're pregnant, you can identify, right? She has great oral hygiene. Okay, she's a wonderful individual. She's clean. She has good records. And so I said, okay, let's give it a try and see how things go. So she came in and, as I mentioned, she's class 1. Okay, so she's class 1 molars of malocclusion with moderate, to severe, I should say, of crowding, especially the lower. And so I looked, and what I did is I said to myself, do I want to move all the teeth, or do I only want to move some of her teeth, right? So especially for adults, we gotta identify, right? What, like I said before, what to do, what not to do. So in this case, if you look, she has great occlusion. Her posterior occlusion, both sides are wonderful. If you look at her arch individually, if you look at tooth by tooth, if you look at her lower arch, you can say, well, if you look at the back, the second molars are lingually tipped. You can really, look at the top and then look at the bottom again, and she has her third molars. Should we do anything about that? My rule of thumb is always remember what not to do. Always sometimes what not to say, right? So, if she has nice stable occlusion in the back and she's healthy and functional, do I want to open a can of worms? I don't, right? She has nice, healthy, stable TMJ. So I decided in this situation, I should minimize or try not to move anything in the back and try to resolve the crowdings by moving the rest of her dentition. So I said to myself, perhaps, bicuspid to bicuspid of some sort, right? So let me go to her, I'm going to show you these. So this is her treatment plan, right? So I'm going to show you her treatment plan. This is her plan. Okay, so I did a lower incisal extraction for her. Okay, and then I did some IPR. But if you look, I did not change much of the posterior occlusion at all. Back here, I did not do any movement in the molar. Okay, I want to keep her stable. I want to address her chief complaint, right? I want to resolve her crowdings. She said her teeth stick out, so she has some protrusion. Okay. But I did not really move any of her back teeth. And going back to her pictures. So in this case, this was February 2022, right? So she went through a set of aligners, and then let me show you her next set of pictures. And after I show you these, I'm going to show you how I did them. Okay. So here's another. Here. Oh wait. Sorry about that. I went to a different person. Here's is. So her final. Okay, so this is her progress. And in progress, this is December, right? So in December, she's already extracted her teeth. She's had aligners for 10 months, okay? And if you look at her teeth compared to before, it's a tremendous big jump, right? So let me go back again. Initial. So she has crowding on the upper, she has crowding on the lower, and we extracted a lower incisor. And this is her progress 10 months later. So she's already level aligned. She's wearing only aligners. I did not move the posterior teeth. Okay. And then I'll show you the finals. This is after she took her braces off for a while. I wanted her everything to heal up. So this was taken in September 2013, and she's already done. Okay, but she really finished early on in the year. I believe she finished around April or something. So the whole treatment, lower incisor extraction, with everything, all the refinements, she was able to finish the case, in less than a year and a half. So to me, that's pretty good, but it really does require a great patient, and that's where the compliance comes in. So I'm going to go back to here, and I'm going to just go do an overview before I start doing her treatment planning to show you all. So here you can see she was started in March 2022. So she had all her aligners then, and then she came in December. And in December, she had a refinement. And then in January, I then had another refinement. And then in March, so here you can see I did refinements, literally, if I show you her appointments, I'm able to have her come in and have her come back literally within a week, sometimes even the same day or the next day. And then I would do a refinement as I go through the clinic hours, and then my staff will be able to do in-house printing and produce the aligners, and then we would give her a month with the refinement, another month worth of refinement. And as you can see, the very last one was in April, and she has no more refinements. So really the whole entire treatment, it started at 3:30, right, which is basically April, and then she finished in April. So in 1 year, we were able to achieve a treatment result of that sort. So, I consider this very fortunate because she was a great patient. Compliance really does matter. So this is what's possible. Now what I'd like to show you is how I look at a new case. So in this situation, what I will do is I will open up a new one. And I'll do Clarice. So we can do, and then we can go back to when she first got scanned, which is in February. And as you can see, I don't know if you guys can see this, but the last one was in April. So I was talking to Frank and I was saying, we really want to, show you how I go through all this. However, I was thinking to also mention that as I'm doing this, remember we all have staff. I have my orthodontic assistants, right? I have my staff. So really, they're doing this part. When I come to my computer, this portion is already completed. Okay, this portion is usually already completed. But I'll go through this real quick. As you know, right now we have automatic tooth positioning, and I always tell my staff to, just double check everything. AI is incredible, but AI is something that is also improving as we speak. So a lot of times we need to, remember it's an 80-20 or 90-10, right? AI helps us, but we also have to help the AI, right? So human intelligence is super important. But certainly, these automatic tools and features help us tremendously with time. So as you can see, we would look and something in here, I'll be honest, even though this is not perfect, but am I really moving that tooth? I've already decided in my treatment plan, I'm not moving this tooth, right? So a lot of times for me, knowing what I'm going to do and what I'm not going to do, I would prioritize where I would focus, when I do treatment plans. So here, as you can see, everything is identified. Very nice. Doesn't really take me that long. Depends on the scanner, we use. This here would be nice. We have all that. This is good. Sometimes this would affect us a little. We want to clean that out. So usually, as I mentioned, my staff would do this, right? So as a orthodontist, as a dentist, I personally don't need to worry about this part, for my office. I always want everyone to check and double check everything. I would look at the general location of the roots. Sometimes we do need to adjust that. And then I always think about the central group, and also I think about where do I want my final occlusion, going to be positioned. And with that, a lot of times for the molar, for example, I would look at the buccal cusps, and I would say, well, where do I really want, the final position to be? And based on that, a lot of times I would determine, how to position these. Once again, this is usually done by my assistants, but I do check. I do come back here and I check because it's important to kind of visualize and think about where you want things to be at the end. And in this case, molars, I'm really not going to be moving much. So, but I still kind of want to just make sure that it is generally in good alignment. And yes, sometimes you do see these red, but we all know that it's not perfectly, matching what the patient has. So even though it's red, it doesn't need to be adjusted more or less. So, with the diagnostics, we always want to kind of do a little overview, right? We want to make sure we understand, you know, the spacing, which we can, visualize on our own sometimes. And then also, we also want to look at the Bolton, okay? The Bolton is very important. When there's too big of a discrepancy, we'll be able to just, decide, whether and where we want to do IPR. So for treatment in this situation, when I look, right, I look at the arch and I'm like, okay, she has an arch, but it's very kind of narrow in the front. So maybe we can do a little bit of a dental alveolar expansion, but not too much. On the bottom, we've already decided to do extractions. And based on the roots, I always look in this situation between these two. They're pretty similar, but I would probably pick the one that's more, labial oriented. So this would be the one that usually I would extract, right? So for setup, um, I would extract that too, so I know that which ones I'm doing. And then in her situation, I do know that her midline is pretty on with her facial midline. So because of that, I have a nice midline to work with. And a lot of times, as I have, always learned in orthodontic residency, we treat to the lower, right? We treat to the lower. So we look at the lower, we look at the top, and what we want to do is we want to position the lower. So we want to, what I do is I always try to get the lower incisors of what I want. In this case, this lower incisor is going to be the one that's more or less in the middle. So I would try to get that where I want. Okay. Right, hit lower again, and I would look at it, and I would look and imagine, envision. Okay, and over here, I always put it in this setting because here I can go back and forth. If we're in the other setting, it would just automatically move, which would be less. And I like to, because I've been working with this for a very long time, what I usually do is I like to do everything manually, step to steps on my own. And I've just gotten really used to it, real comfortable with it. So now that I know the lower incisor, I envision where the surrounding envelope of bone is. And I can say to myself, I think that's going to be good. That's going to be healthy. We're not violating the envelope of the, labial or the lingual, cortical plates. And, with that, then I would say, okay, in this situation, I will probably move this over this way without rotation first, only because one movement that is more linear or more rotational, like one type of movement, I should say, at a time is always beneficial. When you combine, rotations, with tipping and turning and linear movement, then it becomes a little bit more difficult. So I would say in this situation, I would try to go here, right? And then what I would do is come over here and then come back here and see where that is. And then I will add another one. And for this, I will drag it, let's say up here just for the moment. But, oh, where did it go? So let me take this one out. Let's just do that for now. Okay, we'll just add. In this situation, I would then more or less position it to the end. Where I want it to be. That. So what I'm going through now is more or less like my everyday routine. And what I mean by that is as I'm working, I would take a break and I would come back and I would, work on a patient's case. And so in this situation, we have that. I really don't want this here. So if I delete it, it'll connect the two. And that would be there for this one. Once again, I would want some sort of a linear movement. Okay. So if you look, it's more linear, right? And I will come back here. I'll add another one. This new one to be more or less in the final position. So something here. How would you? Once I get that, I want to match everything else. So I put them all in the end first. So put all at the end. But look at where, like if I look here, you see how the root looks a little bit more lingually inverted. I look at everything. So I want to make sure I'm always respecting the periodontium, always respecting the bone. So if I know right now there's collusions, we're going to fix that when we do the staging. But at the moment, if you imagine the trough of bone, the envelope of bone that you're able to move around with, we're not violating any of it, right? And that's very, very important. Very, very important. So let's just do that for now. Then I will check the top. Always treat, right? Always treat to the bottom. Come back to fix this real quick. Read that. And then we'll come back to the end. And then put this one. And tipping. Always remember, tipping is easier, right? But in this situation, obviously we don't want to tip. But a lot of times, always remember, sometimes you can tip first, when you move. It's like a tip edge mechanic. Don't know if any of you guys heard of that mechanic before, but there is a orthodontic philosophy called tip edge. So you can, tip and move, tip and turn. A lot of times that would help. So in this situation, I would probably over here, just get that a little bit aligned. And sometimes I will zoom out because when I zoom out and I look based on the anatomy, I can tell, like this root, you kind of gotta like extrapolate. So Here we go. And do that. There's spaces, we definitely close it, but we don't want to close too many. We need to retract here a little bit. Well, now we don't have any spaces, right? But we do have collusions. So I'm going to deal with that in a little bit. You know, we have our automatic, you know, checks. But at the same time, we can also do it manually. In her situation, okay, if you look, she has a very tight, very, very narrow arch. Remember I mentioned about the narrow arch in the front? It's very narrow in the front, right? So, and she has crowding. So in this situation, we can do a little dental alveolar expansion, but we don't want to violate too much, right? And my rule is always 1 to 2 millimeters. I'm okay with that. But anything more, perhaps it's not going to be too healthy, okay? But before I do that, I always want to say to myself, okay, dental anatomy 101, right? The first bicuspids, the mesial surfaces, if you look at the first bicuspid roots, there's always an extra space and there's always an indentation here. If you look at the anatomy of this 1, 2, everybody has a little indentation here, right? So you can really take advantage of that, okay? So which means from between the canine and the first bi, you can do plenty of IPR, okay? Plenty of IPR. Plenty doesn't mean a whole millimeter, but I can comfortably say that we can easily do like 6 millimeters. 6 millimeters to me is not something that is going to hurt. Okay, and then of course, if you want, you can strip or IPR between these two as needed. But let's say we do 6 here. Looking at the anatomy of her teeth and looking at her occlusion because she's really tight, we can do a little bit of dental alveolar expansion for her. But we don't, I usually try not to go over 1 millimeter to 1.5 millimeters at the very most for adults. Okay, so if I want to do a little bit there, I could. I can do a little, you know, maybe 6 millimeters. And then I take a look now, I take a look at her anatomy of her teeth. So I look at her teeth, and I'm like, well, you know, I can do a little tipping, right? I can do a little tipping. It's not just translating, because translating is hard. Tipping is easy, right? So you can always try to strategize and do a little tipping, okay? So we did a little tipping. Probably want to intrude a bit because she does have the overjet and the protrusion. When you intrude, you also gain space. So when you intrude, you can retract, right? You can intrude and retract, right? So in this situation, I would say, okay, I get a little intrusion. I can retract a bit. You know, we don't want 7, we want 6 there. And between the lateral and the canine, a lot of time we can get about 0.5 millimeter, okay? 0.5 millimeter. So I always start with what do I have that I can do? So I can take this 2. I will go up and retract. And that's 5, right? And then now at this point, you know, we have the front. And what's easy at this point? What's easy right now is you can either retract first and then rotate, but I like to rotate, okay? I like to rotate first. I like to rotate first. So we rotate. In this situation, we're going to say, wow, we have a lot of collusions, right? We have a lot of collusions. So we need to address that. So here, if we do maybe 0.3, 0.3, round that off a little bit, bring this out maybe a little, 0.5, okay, and got that arch development, got more or less this there. Want to intrude a bit more. Okay, and if you look at the angulation of the root, you can tell tipping, torquing the root a little bit over. We always want to overcorrect, you know. And I always watch, because when you do labial root torque, right, you got to remember the bone. Very important. So if I have anything like this, I have to think, is my patient a teenager? Or my patient, in this situation, she's pregnant. So her bones, you know, they're going through a lot of, you know, cytokines, hormones, you know, all kinds of changes, right? So she can afford perhaps a little bit more than usual, but at the same time, slow things down, right? So if you slow things down, if you move people's teeth super, super slow, you can probably do all kinds of stuff, you know. But I know we don't have time. We need to run a business, and we need to make sure, you know, we finish everything in a timely manner. But at the same time, if it's possible and you communicate with the patients, then, you know, a lot of times they're okay with it. So here, I want to come up to the top again and study what I've done and see what I still need to do, right? So we have 0.3 millimeters on top, and for 0.3 millimeters, it's not bad, depending on the shape of the teeth. Okay, she can afford that. But over here, 0.9, that's too much. 0.5, that's a bit much. 0.4, 0.1, that's a bit much. So in this situation, I would say, you know, I will probably do a little bit of here. I will spread things out. 0.6. I will go to the 5 here. I will spread this out to maybe 0.3. You know, I gotta watch my midlines. My midline is still good for now. Let's say have 0.3. Now I got a 0.5. You know, 0.3, 0.5, 0.8. You know, if I expand, I can probably do a little bit of expansion if I need to, just a little bit. 0.2, 0.3, 0.6, 0.4. I'm going to say that's doable. Now for the bottom, we come back and study our arch. Is it coordinated? And as you can see, it is, but it's not perfectly coordinated, right? So I have to make some decisions. You know, when I look, the top is okay. But if I look at always both arches. So in this situation, what do I do, right? I have to decide. So we all know that occlusion is important. I did not disturb anything in the back. However, I can play with this a little. coming up to the top, what I want to do, looking on the bottom. Well, this is the lower incisor extraction, so it's not letting me do a lot. Let me just go back. Don't want to mess this up. So I'm going to take that out. Bring this in a little. We have to go all around, right? Back up and look. Now I'm going to say this is not too bad. You know, tug everything a little bit. Everything looks nice. I'm not unhappy. I'll be happy. I'll be pretty happy with something like this, especially at the start. You know, especially knowing that she's more or less going to be needing refinements. And then I want to see, is this really possible, right? So I'm doing a little bit of dental alveolar expansion, right? And then we do have some collusions, 0.3, 0.2. Sometimes if it's 0.3, 0.2, it's like, you know, 10% of a millimeter. I would almost ignore that sometimes. But if it's something this big, then I would consider, hey, perhaps, you know, we should fix it or figure this out somehow. Now, should we do all of this at the same time? Maybe, you know, if it's like a teenager, but for her, for she's an adult, maybe I do want to, you know, break it up a little bit, right? Maybe I'll do use the front and use the back, you know, as anchorage. Maybe you move the 4 and the 5 first. I do want to move things slow. So instead of the dark blue line, I may double it, right? So now it's twice as slow. And if I do it twice as slow, then we know that we're really giving the bones time, right? The root and the bones time so that we're not pushing it so hard. It's like if I push my arm too fast, too hard, I could get a bruise, right? So we don't want to damage that. So I would double the amount. And I would maybe do some sort of a sequential here, right? And for the canine, I might do the same. For this one, I might go there. And then I would start maybe the laterals a little later, right? Give it some time. Slow things down. And then I would perhaps start the central incisors a little later, right? It depends on which one, right? So now if you look, I got the sides going. I got these other ones going. And then there's still space. There's still space here, so I'm okay there. Okay. For this one, which is, you can tell by the light gray, maybe I'll start that one a little earlier. And I can slow this down a little bit more. Because we don't want to have a big gap. We don't want to end up like this. See, there's a big gap there. You got to think what the patients are experiencing, right? The patients are experiencing something that's like, ooh, you know, we don't want that to happen too. So in this situation, we might be able to afford, there you go. Okay, so with this type of staging, we only have this one problem to go with, right? So now we gotta look, we gotta study. You know, we can click it, okay, and fix it, right? Fix the collusions, right? We can fix it, okay? And then once it's fixed, we still gotta make sure all the IPR and everything is in good shape. And for this, I think that's pretty cool. You know, I think that's pretty cool. Okay, and then now the whole thing will take 28, right? 28 is, it depends, right? So if you look at the case, I pretty much finished the case like within a year and a half. But how long do the patients wear the aligners? This is where it's very individualized as well. Here's another tip and trick, right? So if you find out they're so good, they're so good, you can have them wear it for 7 to 10 days. I never say 7 days or 10 days or 14 days. I always give them range because I let them know it's up to them, how these aligners will be, working and how good it's going to work, right? So it's up to them how hard they work, right? How much they wear it. I tell them this is 0, this is working. If they wear 20 plus hours, it'll be 80 to 100%, which is great, right? But if they wear like less than 20 hours, like 18 hours, I tell them it's almost like 0 because it's like pushing a car up a hill. You push, push, push. And even if you wear 20 hours a day and then you skip 4 hours in a row, it's going to have time to roll all the way back. Right? So that's one other item, it's important. And I always stress it to the patient. I repeat that 1,000 times a day. I feel like I do. Because even though I've seen the patient like, every 8 weeks or so, because I try to track my patients pretty well, I still remind them. Because the more you say it, the more they're scared to come back and show you something that's not working. Because you mentioned it so many times, right? You make them guilty so they'll remember it, which is really helpful. The other part is this. The other part is, I must say, you gotta tell them, when you wear an aligner, every new one you put on, it feels like the last one. It feels like loose almost. It's barely tight, right? A lot of patients are like, wow, this is really tight. It's finally working. And I say, oh my Lord, you're off track. You're probably 3 to 5 aligners behind because it's tight. Because there's so little difference between each aligner that on the day one, if you just give them a 2 or 3, they can still pop it on and feel tight, right? So every one that the patients wear should be pretty loose, right? So when they wear it, that means everything's tracking. The teeth are moving. So the next one is so close to the last one that you don't really feel a difference. It's like wearing a brand new pair of socks. So you always tell them, everyone should be just like the last one, like a new pair of the last one, right? Then things are working, okay? So that's another something that's really important to remember. So now that we have the top, let's go to the bottom, right? Here's the tricky one, okay? So here's the bottom. So I promise you guys it won't take too much longer. I know I'm trying to speak as fast as I can, but I'm just so excited to have this opportunity to share this with you all. And I know, Frank, our CEO, is going to kill me because he said, please don't do everything within 30 minutes. And I think I've already, it feels like he probably thinks I'm going to take 3 hours now, but I'm going to finish as fast as I can, okay? So over here, so if you look, okay, I open this up and I'm like, okay, that's going to have so many collusions. This is totally not going to work. Correct. I do agree with you guys, right? So what do we want to do? These two are our friends, with nothing in the middle, right? So you want those two to really, start moving first. So we come here and we go, oh, here's the gray one. So we know that one's going to be good, right? So we want the 2s to be later. Let's say, you pick a start, okay? You pick a start. You pick the start, the adult patient, and then you can pick this one, which is this one, right? So that's going to start, and then you pick this later. So I always see like that is pretty good, but we probably don't need to start that there, right? So let's say something of this nature. So you start somewhere, right? So I take a stab at it, right? I take a guess. I'm like, okay, that's moving. That's good. That's good. I like that. Oh, okay, so now this one is moving, right? So if this moves, is that going to start bumping? Oh, well, that's not bad. I ain't complaining. I'm not complaining. I'm still not complaining. Oh, there's 2, but at the end is 0, right? So over here, there's a little 2. Okay. So what do I want to do at that point? So I can click automatic, or sometimes I don't even click automatic. I would just say, well, why don't I just not let it rotate for a while? So I would pick a spot, let's say here, okay? And then I would pick a spot, and I would say, do this again. Hmm. I would do that. I would just keep it so that it almost looks like it's, and then, okay, if that doesn't work, this is what I do. Okay. Kind of don't want 29 aligners. That's the thing right now. My thing with this is I don't want 29 aligners. So I would think to myself, always in my mind, how many aligners do I really want in the treatment? And in this situation, I would love to try to keep it around 25, perhaps. When I do, so I would start playing with it. I would take a look at it. I'll say, okay. Perhaps this is something that I would, so I would study it. I would say, this is where the 7 hits, right? So that's where the 7 hits. Lower right one is over here. It really started rotating. Perhaps that's not what we want, right? I don't want it to rotate, right? So I'm going to say, at this point, I add 1, and then I would keep it like it was before. Let me see what happens there. Even here, I would add 1, and I would do this. Okay. So at the end, if you look, I only have 0.1 and 0.1. Okay, so that's one option I can do. The other option is I can go back, but I'm not going to go back because I'm going to be pretty happy with this. So, because I can do the auto correct, right? I did that for the top, but I just want to show you guys, when I'm doing this bottom one, how you can also manually do it. You don't always have to click the auto, because sometimes when you click the auto, it changes a lot of different things, and you might not want that. Or what you can do is you can click the auto correct, okay? And after you do the auto correct, okay, then if you don't like it, you can do reverse, and then you can try to, play with it on your own. So here we have 28 aligners. If you look at the top and the bottom, we only have 0.1 and 0.1, which is really not much. Okay, and then we have a treatment. Okay, so with 28 times 2, even if it's 2 weeks, right? It's like a whole year, right? 2 times 28 is 56, which is 1 year. If you do 10 days or if you do 7 days, you can do that as well. And if you look, plenty of time, plenty of time. Okay, so this is how I do this. And then I, of course, go to the attachments. And in this situation, because I want to ignore the 0.1, I'm going to skip it. And for the attachments, there's many different and various attachments that you guys can use. And I'm going to come back and give you guys another webinar about kind of like my thoughts and my strategies, how I work with Titan, and how I have Titan help guide me to determine all that. All right. So here's what I want to go next. So that is a process of how I treatment plan, but of course, I do it kind of quick because I do these in between patients, and sometimes in between patients, when I see patients, I think about what I just did, and I will come back and finish up a plan. And this is not, like easy IPR, easy treatment. It's not a mild case. This is kind of like considered a moderate case. Some would even say this is moderate to severe, but I think it's more of a moderate situation. So I just want to show you guys what I did previously, right? So previously, with her case, what I just showed you is what I did, right? But this is what I did for her back then. This is like years ago. So I have her with attachments. This is a new version of the software, so let me check on something. I think I need to update this part this way I can show you exactly what I did before. Because the new version of software, I think sometimes when you open previous treatment plans from a long time ago, it might not be perfect. But let me just do this so you can see all the attachments. Okay. So, I did have different staging setup. Of course, what I did today is different than what I did last time, right? Because every day we're different. So, what I did last time is hopefully pretty much similar, right? So I did some movement and I should show you this. So I should, try not to have too much collusion, right? So there was some collusion here, 0.3, 0.1, 0.2 millimeters. I'm not going to complain too much about that, but, there's some staging involved, right? And then, it was 24. I did have her wear it, I think, like 2 weeks or something. I think she ended up doing like 2 weeks. Don't be afraid of having your patient wearing it longer, because if you look at this case, I mean, she's still finishing a year, right? Pretty much in a year. So actually, I think I did pretty much the same. So look, I expanded the sides, right? The bicuspids, and then I moved the front. And then at the end, for this one, 0.6, 0.5, I did a 0.4 here, 0.5, 0.2, 0.3, 0.2. Okay. So no complaints there. So this is how she started, right? Let me go back and so that was March. So here is her scan in December. Okay. So she came back in December. And let me just I want to be real. I want to be real with everyone. Here's this is her chart. So we started in March, deliver 1, 2, 3, 4. I watched her well. We IPR'd a little bit more here. And then when did we scan? We scanned her, yep, 12/7. So by then she wore 21 aligners. So she did 21 aligners, and then we scanned her. So let's go back here. Let's go back to here. Just want to share with you guys something. So in the first treatment plan, we had 24 on the bottom, 22 on the top. So she wore 21, right? At 21, I guess at the time I'm like, hey, things are going well, but I think it's time for a refinement, even though you didn't finish the whole, 22, 24. But that's pretty close, right? I have a lot of patients halfway through, they're falling apart and I have to scan again for refinement because they don't wear it. She's actually pretty good. So at that point, in December, we scan her and then we go back again. So I made a few more aligners and let me look. So let's switch to here. We'll put yes. So this is her at that point, right? This is her at that point. Oh, so you can see everything's not bad, but these two, right? The lower right first and the lower right second central incisor are still a bit rotated. what did I do? So I overcorrected it. If you look, right, this is where she started. Actually, yeah, hold on. So this is 0, right? So actually she didn't look that bad, right? So instead of just making it perfect, I overcorrect. Remember I mentioned previously, overcorrection is your friend. What you see sometimes is not what you get. So what you see in the aligner, you got to really think about the patient. You look at the back, I didn't really do much. I think, I'm not sure, she might have taken that out later, or maybe she left it, the third molar. But I overcorrect, and then we watch her, right? Let me see what I did in top. So for the top, I just rounded out a little bit more. Okay, so if you remember how her front was really crooked, so I guess I wanted to tighten it up more. So, sometimes I do finish with 0.1 all around just to make sure things are nice and tight, right? So that was in December. Do we have a picture for December? Oh yeah, that is December. Here's the progress. The middle one is December. Let's wait. So this was her December. There you go. This is her in December. This is the one when we scan her. And yep, as you can see, these are the two that needed some more refinement. But overall, she did great. Her occlusion in the back is good, as you can see. That's on the left side. This is on the right side, right? What not to do, right? Remember, you want to keep the occlusion, you don't always want to have perfect class 1. It's they're not, toys or machines, we're real humans. Everything has to be individualized, right? I mean, even though if you look at the back, you see how there's still a little bit lingual verdict, but they're happy. They're happy and they're stable, so they're healthy, right? So the front is good, the sides are good. I like that. So going back here, so that was the December, she wore 5. And then after she wore 5, she came back January 20th. That sounds about right. So let's see. I think she did it like 1 week each. We gave it to her right away. Because patients come in, and for the refinements, I literally sit down, 5 minutes, boom, 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 I'm done. And then my, Erica, she would just make it. So when she came back, hey, that's not so bad, right? Oh, so I must have done something more. Oh, so here, I wasn't very happy with the roots. So I did a little more. And I did a little more overcorrection as well, right? And a lot of times for these attachments, this one, I don't think I did it, but a lot of times when they come back, before they scan for the refinement, you can reshape it a little bit, okay? You can reshape it so that you have a plane where the force, aligners is the pushing force, where the aligners will push more in the direction, give it more of a directional effectiveness as you want it for the next set. So you can reshape here's another tip, reshape the attachment before you do any scanning for refinements. Okay, so that was, what was that? What did I say? Well, that was here. So 2 on top, 5 on the bottom, and then she came back in March. Not sure what I did for her then, but let's take a look together. So this is March. Okay. So I think I worked on her anterior occlusion probably. Okay, so I did a little bit of more detailing over here. Then for the canine. And on the bottom. Okay. So this is not too bad. I'm not complaining, even though I overcorrected, it corrected a bit. But this is not perfectly aligned. So as you see again, I did a little bit more overcorrection, right? But I kept it tight. I did 0.1 because I kept it tight. Lower anterior, I kept it a little tight. So we did that. That was March, and then here's April. Yeah, she looked pretty good. So April, I mean, I'm not complaining. I'm pretty happy. You see how? So wait, hold on. There you go. That's her. That's 0, right? 0 is where she came back. So that's corrected. So the overcorrection worked, right? And then the top is pretty symmetrical. You know, I ask my patients always, are they happy? Are they okay? And when we see these green things, sometimes you have to occlusal adjust a little, okay? Don't be afraid because you don't want any traumatic occlusion, right? And then you do want contact in the posteriors. So that would be good. And then, yes, if we blow everything up, you can probably do a little bit, you know, 1 or 2 degrees, you know, every which way. But you gotta look at the patient. Are you happy with your smile? Do you want me to shake the teeth a little? And sometimes they don't want to. Sometimes they're like, I'm so happy. Can I just finish already? Doctor, you're doing so many of this refinements, you're killing me, right? So at that point, I think I'm pretty much done, right? That was April. So yeah. This is the one we did. So today, 123.25. So we did that today. That's the one I showed you. So yeah, April 2013 was when she finished. And let's just go back here. Look at her final again. Her final? No. Yeah. Oh. Right. Progress. So slow. Looking it up. Oh, I think it was. Oh, wait. That's not what I want. Sorry. Well, we could. Why not? Let's just do that. Let me is sorry. This is a cloud-based software, Ortho 2. I don't know if any of you guys use it. It's great, but it's not perfect. So this is her sides, other side. This is her lower. You know, it's pretty aligned. I'm pretty happy. You know, this is her upper, nicely aligned. And this is her overall. So that's for today. I know I talked a lot. I know I said a lot of things, but you know, I'm just so excited to be able to share all this with you. And she's a happy patient. We can all do this. It is not very hard. If I can do this, everybody can do this. Yeah, so that's my talk for today. It's how is it? 1:14. My apologies for you know, going over some of the, you know, limitations that Frank had given me. So apologize, Frank, for that. But it's really exciting to share with everyone. Now, with that all said, I'd like to ask, you know, you guys, for anybody who's got questions. Let me see. How do I unship? How do I go back to? Oh, nice. Are you guys all still there?
Dr. Mario,
Yes.
can you hear me? Thank you very much beforehand for the fantastic presentation. It was wonderful. I was wondering whether if there is any prefabricated suggestion for the attachment. So does Titan has a suggestion for the attachment? Is there a protocol by Titan how to choose attachment, or how do you prefer to do this?
So attachments, we do have protocols. We have, you know, our kind of AI assisted, you know, guidance as to where it needs attachments. The thing is, so many doctors has voiced their opinion to us that they wanted to, you know, have their own preference. So we have a library of attachments, but for each of the attachments, if you select that attachment, that, you know, the one that you prefer, I don't know if you have a preferred attachment, after, I don't know how much experience you have with aligners, but a lot of people with, who've done a lot of cases, tend to have their preferences, right? So you would pick the shape of your preference. And then once you put that on the tooth surface, with the force factors, the one that the technology, the feature that we have that understands where the forces need to be applied, it'll kind of position that preferred attachment where it needs to be, when you position it at a certain spot on the teeth. And so with that, it'll help you have the most, effective, forces, to achieve, the movements that you've performed. So that's one option. As far as, having like complete set of default attachments that perhaps if you just press a button, it's like the Titan default, and then all the attachments will just be placed for you. I'm gonna let Frank answer that part.
Hey, Ty.
Thank you, doctor. And excuse me again, I know this is you specifically stopped the lecture and you wanted to continue with the attachment on the next session, but apologize for that and thank you for the explanation.
Oh,
Mr.
thank
Frank.
you. I appreciate your time today.
No worries. One thing to add on top of that, yes, we do. So attachments, we're very focused on having attachments, be useful. And we are about to release also a big update on attachments, for the AI. So we do have a presets. So there is, Ty, if you can go there to the attachment section.
Sure. Let me open this one.
Yeah. So in the attachment section, say by default, we do the analysis and we tell you what we're suggesting and things like that. But in the panel on the left, you see that there is presets. So Ty, can you click presets? It's the second button from the top, that one. So presets are a set of aligner attachment placements for different scenarios, and you can create your own scenarios. So let's say that you do, I don't know, this deep bite. Let's say click deep bite, apply. Okay, apply. So it will place attachments in several positions depending on that protocol. And if you have a protocol that you use very often, you could place your attachments and then just say create preset, and from that point on, you can quickly place them. So that's mostly the ways that you can work with attachments. You either see the analysis that the software does and place them manually. You can use the presets as those protocols, or you can use the automatic placement. Now, the automatic placement that is in the current live version, it's not very good. That's why we have been working toward making it better, and that's what's going to be released in the next version, because the previous automatic placement was not using all of these rules, all of this coloring and tooltips information. It was just placing based on individual tools and things like that. So now in the new version, you can click place attachment and it will do, see, wherever is needed based on analysis. Hope that helps.
Thank you, sir. It was fantastic. Thank you very much.
Thank you, Frank.
Is there any other question?
Hi, Frank. This is Francisco Razo. How are you?
Hey, how you doing?
How you doing? Mario, thanks for your presentation.
Thank you.
I really enjoy it, and always when I see Titan, it always open my minds, and I start to dream. And couple things. No, your presentation was outstanding. The case selection was really good. It's an easy but difficult case. Two concerns that I have. Of course, this is a presentation, and I hope at one point we don't spend that much time doing treatment plan. and we'll do AI, and I think Frank is working on that. And with kind of like an outcome simulator, the patient likes to see a simulation really fast, and I think you have it. And one thing that I think it will improve everything that you have is the use of Combin. I'm a radiologist. I'm obsessed about Combin, and so because if not, we are going to keep using the same habits that we have for 25 years, which is working with the crowns and dream about where the roots are positioning. And when you are showing what happened if we do root torque, and I would say, remember, you have to think about this. And physiology, I hope physiology will be that easy, but bone physiology is unpredictable, and the only predictability is the use of Conbeam. So Frank, commend you for this software, an amazing software, and I hope the Conbeam is coming. And thank you very much for your presentation and your time.
Awesome.
Thank you. Thank you.
Yeah, thanks. I'm really glad that you brought that up. It's a so we have a segmentation of the CBCTs that is coming very soon. Most likely that will land around the same time of AAO.
Perfect.
But we do have another thing that is gonna help even more doctors because combines are the perfect, you have all the information. Problem is that a lot of doctors don't do CBCTs for every single patient because of the radiation and all that. So you lose a lot of doctors, a lot of patients, a lot of cases that you are not going to have that information. So we have been working on obtaining that information from the X-rays with pretty nice AI that we have been trying it, and it's producing. I mean, it's not the same as the CVCT, but gets really, really close. So we're going to be announcing information about that and opening that to the early access very soon. I cannot give like an exact estimate because
Yeah, no,
there's
the problem with 2D projection is the geometry, and it's very difficult. Again, we will make the same mistake as like we have been doing it for years. So the fact that radiation dose is not a concern anymore.
sorry.
So I think
Did I lose the audio?
radiation dose is not a problem, and so it's all about, and this brings me to
Hey
one
Mario,
point
can you
we
hear
need
me?
to do.
I can hear you, yes.
Oh, I lost the audio. Just a second.
So the radiation dose and the point that I'm trying to make is this is an unbelievable opportunity for teaching, and the only way that we are going to bring more and more people to Titan is by teaching case by case, and people have to do one case, and that has to be kind of a certification, levels of certification for Titan, because doing one case, it doesn't mean that you can do it. Then you move into another level of eventually bring, for example, occlusion, TMJ, airways, and stuff like that. So that will be different levels of Titan, and we have to do certification. It's very difficult to evaluate Titan with one case only, and Mario, I wish we can do some kind of like a mini residency for aligners and really write a curriculum for aligners, because I'm telling you
Absolutely.
that we don't know how to treat people with aligners properly. We are just moving teeth, and that is not orthodontics.
Absolutely agree. Yeah, I think my comment about the cone-beam CT is I absolutely do agree with you. I think radiation is really not a big factor. The one item that that I do believe is still going to be a factor is the availability and the cost of radiation, access of radiation, affordability and access, I guess, for globally. But for the ones who do have access, absolutely, we definitely want to have some sort of a algorithm or some sort of a guideline, to know what to do and what not to do, right? Like I mentioned, like you have just mentioned again, with regard to torquing roots, that labially, who perhaps, can afford to do that, who perhaps should not, be doing that. I mean, with braces and with wires, I'm very traditional. I was trained in the Northeast, and we have to respect the intercanine width. We have to respect the roots. But when we look at all these cases, it's like it's almost like Dr. Prophet's 2017 Legacy AAO lecture. He said there's a lot of research, but and that's like research based on traditional research rules, but there's a lot of clinical, results, clinical, worthy data that we just we're not able to extract and have to better understand how the bone reacts, right? And everybody's bone also reacts differently. It's 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 kind of a mystery, but it's not, because we don't want to violate what we already know. But I think we just have to figure out, like a guideline for it going forward by studying the cone beams, right? By studying what people has done, and then what's doable, what's not doable, and who is it doable for, and who is it doable, not for. So I completely agree with you with that aspect. We definitely need more research and more data so that we can explore, all that. And with software apps, with data, then we can create, based on guidelines and what we realize, right? Not just yesterday, but tomorrow, then we can create, softwares that can follow that.
One final comment, Frank, because it's so excited to have you for the first time and talking to you. So one thing that in my opinion is very important, we have the software, no problem. The software is one of the best softwares that have been built for aligners.
Thank you.
The next one is the plastic, and the next one is the bone. So let's pretend that plastic is good. Okay, so we have now the software, we have the plastic, but if we don't have bone, it is nothing that we can do with the bone, with the root.
Absolutely.
So that is why if you in baseball there's 3 strikes, and one strike is enough to kind of ruin the whole game, and to have a strike with bone and with no moving teeth, like for example your case is very gutsy for us to do treatments without seeing the bone and the anterior segment, and we're doing that every day, and I take convinced in all of my cases, but what happens if we really have a very thin bone in the anterior segment of the mandible and we are extracting a tooth? Sometimes closing those gaps are a bear to finish them. And so yeah, no, it's like I hope we can work together to improve because
Absolutely,
I have
absolutely.
very good software.
I tell you, I have, let me show you something very interesting. It goes along with what we're talking about. I have a picture on my desktop, and look at this picture. Oh, let me see if I can get it so we can see it better. Sorry.
Yeah.
Look at that. I show my consults this many times a week, because a lot of consults come in and they're like, well, this orthodontist says no extraction, that orthodontist says no extraction, for example, right? And why are you saying, I need extractions, or I cannot, do what the other guy said, or some other 4 guys said? And I'm like, well, because we have to respect our periodontium, right? We have to respect, we have to, understand what we can and cannot do. And I show them this. I'll take, that's so gross, I hate looking at it myself. But I show them that because, we need to understand, we have to respect our body, in order to be able to do some good. So, everything you mentioned, I think it's the new, it's not new, but it's going to be, realized soon, with really advancement in technology, right? I mean, we have cone beam CT, but cone beam CT is also evolving. So I think that's going to really help. Data collection, real life data analysis, collection of data from all around the world. Not everybody has quality data, but we have an algorithm or a formula to, determine what's quality or not, and then we can collect data all around globally, we can have a lot of data really quick and process that, right? And then look for patterns and and realize many, answers that we don't have, yesterday.
Yeah, at one point, what is going to happen is what happens with implants. The lawyers are going to ask, okay, give me your pictures, give me your records, give me your cone beam. Oh, I don't have
Exactly.
you have cone beam. Okay, so you're dead.
Yeah, yeah,
And so
exactly.
the thing is going to
Exactly.
happen with the aligners cases. So they're going to say the patients that fail, they're going to say, okay, show me your records, show me your treatment plan, show me you did your homework, show me your cone beam. And it's like, oh, I don't have it. Invisalign is receiving cone beams, Spark is receiving cone beams, Angel Align is receiving cone beams, 3D Predicts is receiving cone beams. So we cannot be behind them, and actually we should be ahead of them, and that is why I receive our company receive 120, 150 cases, 50,000 cases per year.
Wow.
So the people are not even know what they are getting into. And so open the eyes with the combi. This is going to be a differentiator, Frank, and we can work together. I love working with you,
So
Ignacio in Ecuador, my big friend, and
one thing
everybody.
to see that I understood correctly. Right now on Titan, you are able to import a CVCT, match it to the tooth, and you're able to see where the bone is compared to the roots. The problem is that it's a bit of a more tedious process, and because there is no segmentation, which we're releasing segmentation for the CVCT, we are not extracting the real roots exactly as they are in the CVCT. But the bone location, you're able to see it and overlay it on top of the model.
The problem is the volumetric rendering is not projecting the real bone, so sometimes it's very misleading. So sometimes when you project the volumetric rendering, it shows like a defect, but it's not really a defect. It's just they say the anatomy that is not allowing the pixels and the boxes to reconstruct properly, and so you have to create a different kind of renderings and
Yeah.
segmentations to be able to capture that, because with the one that you have right now, I don't think is an accurate representation of what you have.
Okay. Yeah. I mean, we're working on segmentation. I mean, the segmentation is is so the segmentation is ready. We just need to place the tools so that you can interact with it in the software. Um, yeah. So we expect to release something very very soon.
I think the purpose of the purpose of why we have what we have is to, serve as a tool to remind clinicians that, hey, don't forget about the roots, right? Here are some virtual roots. Please do, understand that the roots are there. Don't just look at, the crowns. So, based on, typical normal anatomy, you can adjust the root length, the angulation, and based on that, it'll remind the clinician that, if they try to match for example, the root, let's say you have two really short upper central incisor roots, right? They can adjust it and tighten right now so that you can kind of see it, and it'll remind the clinician that, hey, these roots, are kind of the situation with with your patients. And so for me, I think that's kind of the main purpose of why it's there, so that to remind the clinicians not to forget about it. They have to use their, HI, their human intelligence, right? It's not just all AI and computer, and to treatment plan. So a lot of things that we do, even though it's not perfectly accurate to a combing CT and the actual of the patients, but it helps, and it helps remind clinicians. So it does serve a purpose, although ideally, of course, we want something that's perfectly accurate for sure.
Yeah, and one thing that I like is for example, I think we need to create new habits, and I think printing all of the liners is such a big mistake. So it's good that with the Titan we can do 10 by 10, for example. So it's like I do 10, then print the other 10. So in that way, you kind of like are respectful of the bone physiology, which sometimes Invisalign prints like a 60 aligners. It's like, come on, this is too much, huh? But
Yeah, absolutely. I mean, right now what I do is I give out 6 to 8 aligners,
yeah,
and depending on the patient, some patients where, I tell them 10 to 14 days is my typical. It's a lot longer than what everybody else is preaching, right? They're saying 7 days, 7 day, everything. But it also depends on how you program the movements, right? You slow down the movements, perhaps you can do 7 days, because every movement is so tiny. And then you get a fresh one every week. So you feel like there's progress. There's a lot of psychology involved as well. But for me, I always tell them, you have to start with 7 to 14 days, and 2 weeks is good, because nobody's perfect. I'm telling you 20 hours or it doesn't work. And I know nobody's wearing 20 hours, but I tell them that. So they really try. And 2 weeks later, most likely with a combination of the length of time, close to 20 hours, they get there. Sometimes I would cut that down a little bit. I would say 7 to 10 days. And then, I tell them to, mark down on the calendars, but it's very individualized, very, very individualized, and also for the treatment, for the tooth, for the biotype of the patients, which tooth are we really moving and how do we want to move that, body does magic. It really does. It's kind of like the lateral that is in a crossbite, right? You would open a space and then you would bring the lateral forward. How does that lateral create so much bone? Because if you open a space, for the upper lateral, the lateral was lingually, in a crossbite behind the lower incisor, and we move it all the way to the front. How does that lateral, build so much bone on the labial side and end up being okay at the end? It's almost violating the cortical plate as it's moving forward. But for years, right, for decades, we've been doing that as orthodontists. And canine exposures, right? Certain canine exposures, canines move a very far distance, and somehow it has bones, on the labial or lingual side of it, where I would think, oh my God, based on my education, my understanding, that would be very difficult. So I think with future research and data collection and better understanding, we'll have much much more knowledge to be able to do this more predictably. Yeah, for sure.
Great. Do we have any other question? Any other final question? Also, if you are just watching through YouTube, feel free to put the question on the chat and we can answer it from there.
Let's see, I think there's one. Is there one question? Oh, any questions?
Mr. Frank, I
Hey,
Hello? Frank, can you hear me?
yeah, I hear you.
Okay.
Somebody wants to make a question, but then be quiet.
I think it's muted.
Yeah. Mario, it was a wonderful presentation. I love it. Thank you so much for sharing to everybody in the community.
No, you're super welcome.
Yeah, was perfect.
Oh,
Well, if there's no other questions, let's finish it here. And just a reminder, we're gonna have these webinars once a week. And any other question, just you can send it to the WhatsApp group. And we may even answer those, in more details in the next webinar. But yeah, I hope you like this. I'm hoping this is gonna be like a very useful tool for doctors to learn how to use Titan and orthodontics in general.
thank you so much, everyone. Really appreciate it. Can't wait to do this again,
Thank you.
Perfect.
All
Thanks,
right,
Mario.
and reach out to me, reach out to us with any questions, any comments. We love comments, we love questions. We're always looking for things to improve, always looking for things to innovate or to solve any problem. We can work together. We're all clinicians here, and we're all Frank is basically a clinician. He's like studied like gazillion cases already. So we're all here to share and to work together, going forward. Thank you so much.
All right.
Okay,
Have a good
guys.
one, guys.
Thank you.
All right,
Bye-bye.
thank you so much. Have a good one.
Bye.
Thank you very much.